Thank you. That's what I was going to ask about. So this meeting will be recorded and posted on our YouTube channel later today.
Great.
So it is my pleasure to introduce Dr. Kelly Bolton, who is a physician scientist and assistant professor at the Washington University School of Medicine. She has a strong background in medical oncology as well as genetic epidemiology and has done um, quite a bit of work on our topic today. She is well known as an expert um, in clonal hematopoiesis, which is what we're going to talk about today. So, thank you again for being with us. We really appreciate you sharing your expertise and time.
Yeah, thank you. Happy to be here. And so I think I was tasked with talking about clonal hematopoiesis, which from a variant curation perspective is usually more of an annoyance. But I'll talk about essentially, how this might come up in the context of either germline or somatic mutation testing, some, tricks of the trade in terms of distinguishing it from inherited variation, and some thoughts on management and what causes it. So just to start off, well, I'll make this kind of centered around a case. So I do see patients that have clonal hematopoiesis that get referred to me for counseling. Usually it's found in the setting of solid tumor profiling. So for example, when I was actually at Memorial Sloan Kettering, I had a patient that was referred to me who was a woman with breast cancer. And this is actually a second breast cancer, and she had been previously like more distantly treated for her first breast cancer with radiation and a combination of chemotherapy. And then because it was her second breast cancer, she had germline inherited mutation testing done. And so you guys are probably familiar with this, but what essentially will happen is you'll get a report back, and when in the description of the variant, there in rare situations there'll be a description that says that this variant could be mosaic, basically, versus germline. And that was the case for her. They reported, I think this was Ambry or Invitae, but they reported a TP53 mutation at, and they said that it could be mosaic. And so I emailed the company and asked for just some more information on why they said that. And they said that the variant was detected at 30% VAF, which is why they reported in a footnote that it could be mosaic versus germline. And this obviously has big implications, for patient care. And so first, I'll just give us an overview on like what clonal hematopoiesis is. I'll talk about the link between clonal hematopoiesis and previous exposure to cancer therapy, which is a big reason why, especially in our cancer patients, we see an enrichment of clonal hematopoiesis, and what this really means for their clinical management. So first, this is probably kind of basic for you guys, but just to refresh everyone's memory on some terms I'll be referring to. So when we think about genetic variation, of course there's germline or constitutional genetic variation, which is transmitted through the sperm or oocytes, which is present in all cells of our body. And as opposed to mosaicism, which arises at some point during our development, which indicates that there's cells that are different from each other within our bodies. And so, depending on how early this arises during development, it's going to have different implications on health. So, if we think about cancer is a form of mosaicism that presumably, only affects like a cell in our late in our development in like a single, organ. We also know now that you can detect these events, these acquired mutations that are not cancerous, but occur in healthy tissues and that are compartmentalized to a specific healthy tissue. For example, clonal hematopoiesis, which is a mutation that occurs in our bone marrow stem cells, that if it occurs in the right cell at the right time can lead to an expansion. And then kind of in between those two states is something called constitutional mosaicism that basically just denotes this idea that there's a mutation that occurs in a cell kind of early in development. So you might expect that it's present in various tissues, various parts of our bodies, but with variable variant allele fractions, depending on like where in embryogenesis this mutation occurred. So we know that clonal hematopoiesis is like not unique to like this idea that a mutation can arise in a stem cell that leads to an expansion. This is not unique to the blood. Because cancer is essentially caused by the successive acquisition of multiple mutations, and this occurs all over our bodies. And this idea that like cancer is dependent on like multi-steps, like a multi-step kind of process is not new. Actually epidemiologists back in the 50s proposed this initially just based on the fact that you see this really characteristic age distribution for a lot of cancers with kind of exponential growth with or exponential increase in incidence rates with age. And they propose that could essentially be explained by like 5 or 6 steps that were occurring in roughly equal time frames. And so we know that now is the case, that that cancer is fundamentally caused by the acquisition of multiple drivers that just lead the cell to becoming increasingly abnormal. And a lot of this is just bad luck with age. But of course, we know that there's other important factors that play into the timing of these mutations and the likelihood of the mutations occurring. And those include things like environmental exposures and inherited genetics. And the clonal hematopoiesis is really cool in that it allows us to understand like the interplay between all of those things, really just because it's so easy to detect clonal hematopoiesis, because the blood is so easy to obtain, it's easy to sequence. There's been, huge studies in populations, like really kind of with whole exome data or whole genome sequencing data, trying to understand like inherited genetic variation, how it affects different, disease outcomes and because of that, you can basically reanalyze that data and find clonal hematopoiesis. And because of that, we really, understand more than any other type of mosaicism, how clonal hematopoiesis influences human health, and how it leads to leukemia in some people. So basically, if you want to find clonal hematopoiesis in blood sequencing data, what you do is you try to essentially filter out like inherited mutations, which the way we usually distinguish that is based on the VAF. And so you look for mutations that are occurring at low variant allele frequencies. And since we know the mutations that tend to drive clonal hematopoiesis, you can perform kind of targeted investigation of these low frequency variants looking for those specific types of mutations. And from these initial studies that were done, in 2014 and beyond, we know that age is by far the most important predictor of clonal hematopoiesis. So, young people do have clonal hematopoiesis, but it's present at very, very low frequencies that are hard to detect. So if you're doing something like whole exome sequencing, which is usually, a medium kind of depth sequencing, usually performed at, a depth of, I don't know, between like 50 and 100x. you're not going to detect clonal hematopoiesis in young people. You're going to detect it more in middle-aged to older people. And the types of mutations that drive clonal hematopoiesis are really the same mutations that drive hematologic cancers, especially myeloid malignancies like MDS, which I'm showing on the right. And the reason why like these types of mutations overlap with clonal hematopoiesis and myeloid malignancies is makes sense. It's that if you have the same types of mutations that lead to cancer, like fundamentally how they're doing that is they increase stem cell self-renewal, they improve like survival. And so those same types of mutations are the ones that you would expect that would be able to drive these clonal expansions in the blood. And, one of the problems with clonal hematopoiesis in terms of just like, in our day-to-day life dealing with germline mutations is that they overlap this common variants that drive cancer susceptibility. So here I'm showing basically, this is a distribution of genes that are involved in clonal hematopoiesis from the UK, from analysis that we did in the UK Biobank. And I'm focusing, I took out DNMT3A because that would be like, a huge spike in the beginning. But if you focus kind of later on down in the spectrum, you can see that there's, clear overlap, like TP53 is a really common gene we see in clonal hematopoiesis, CHEK2, ATM, NF1. And it can be hard, to really figure out if those types of mutations are CH versus rare germline variants. And so there's ways that, we in my lab deal with this bioinformatically, and that commercial labs, deal with it. And really fundamentally, the big way, like I was mentioning before, it's just the VAF. So, the closer something is to 50%, the more likely it is to be germline. And usually commercial labs, depending on the lab, but they'll report a variant as being possibly mosaic if it's less than, like 30 to 20% variant allele fraction. So, things that are like between, 30 and 50%, though, like that can be actually hard. It can definitely be a germline variant, but it also can commonly be CH. So other kind of ways that you can distinguish CH from rare germline variants is doing things like going to NOMAD and looking at the age distribution of the variant, which is actually NOMAD now reports, I think largely to help people try to understand whether something is CH or a rare germline variant. So, what you'd expect if something is CH is that you'd see an enrichment of the variant, like in older people that detected in older people compared to younger people. But the problem is that even these germline databases like NOMAD, of course they're going to be including CH variants and calling them germline, and same with somatic databases. There's going to be a mix of kind of things that are really CH and really germline. But overall, if you see this enrichment in older people, it suggests that this could be more likely to be CH, versus if you see that the variant allele frequency is perfectly aligned with like the age distribution of the population, that's more in line with it being germline. But the real way that you would want to distinguish a germline variant from a CH variant in a clinical setting, especially things like a TP53 mutation, where it really has a big impact, on clinical management, is to test multiple tissues. And I've done this before, with patients, and essentially what, you try to do, the perfect scenario is that you actually do a skin biopsy, culture skin fibroblasts so that you remove any blood contamination. And if something is present in both like the skin fibroblasts and the blood at roughly equal VAF, close to 50%, that suggests it's germline. If something is present in the blood but undetectable in the skin fibroblasts, that means it's clonal hematopoiesis. If it's present in both the blood and the skin fibroblasts at variant low allele fractions, that could represent constitutional mosaicism. The issue about clonal hematopoiesis doesn't just come up from the fact that we want to distinguish it from germline genetic variation. It also does have clinical implications for the patient in and of itself. Really, the biggest reason is because clonal hematopoiesis does represent this potential first step in a multi-step progression to hematologic cancer. And like I mentioned before, the really the most important thing that predicts clonal hematopoiesis is going to be age. There's also increased presence of clonal hematopoiesis among smokers, among whites compared to non-whites. But also, people that have been exposed to cancer therapy have higher frequencies of clonal hematopoiesis. And that has implications for their risk of secondary malignancies, like secondary hematologic cancers. And that's what I'm going to talk about a little bit now. And the reason why this is clinically relevant is because actually, exposure to cancer therapy is, besides age, is the biggest risk factor that we know of that drives hematologic cancer, like myeloid malignancies. And there's different relative risks of getting a hematologic cancer after a diagnosis of a solid tumor that varies based on the solid tumor. And the reason for that is because the types of chemotherapy that we give to different solid tumor patients are different. So people that have sarcoma are given really dose dense regimens, heavy in alkylating agents, heavy in platinum, and so they have the highest relative risk, compared to other types of patients. But really, most solid tumor patients do have elevated risks of myeloid malignancies compared to people that have not had a solid tumor diagnosis. And so, like I said before, CH is a really cool tool to understand myeloid neoplasm development. And so understanding how oncologic therapy impacts CH tells us a lot about how, people go on to develop secondary myeloid malignancies with chemotherapy. So now I'll talk a little bit about research from my group on that we published a few years ago. So we performed a large scale analysis looking at 24,000 people who had their blood sequenced for clinical purposes. We performed CH calling in all of these individuals. These were a mix of people who had different types of cancers because this was just like a clinical sequencing assay. Most people were treated before the blood that we sequenced was collected. Some of them were untreated. And they got the types of therapies that most solid tumor patients get. So a mix of different types of therapies. And so overall, we saw that, CH was present a little more often in solid tumor patients who had gotten any type of treatment. But it's really specific genes that you see that are enriched, like TP53, CHEK2, APTM, PPM1D. And these are all genes that are important in the DNA damage response, which I'll get to in a minute, why we think this is. And so, the people that are most likely to have CH are people that have been exposed to radiation therapy or cytotoxic therapy, especially people who have been exposed to topo-2 inhibitors or platinum. And even among platinum, there's differences, like carboplatin seemed like it was the agent that conferred the highest risk of clonal hematopoiesis. And so people who have been exposed to lots of those drugs had even higher odds of having clonal hematopoiesis. So, suggesting that there's a dose response relationship here. And, you know, interestingly, like this idea that, you know, different therapies, maybe, or different exposures impart different risks of clonal hematopoiesis by gene is something that's not just limited to cancer therapy. Like we and other people have shown that certain genes are more enriched in older people than in younger people. Certain genes like A6L1 is more enriched in smokers compared to non-smokers. So there's, you know, definitely like gene-specific environmental associations that we observe with clonal hematopoiesis. And so, you know, again, you know, a fundamental question is like, how much does treatment cause these mutations, or how much does it expand pre-existing mutations? And to answer this, we collected sequential samples in 500 patients, where there was at least like 18 months from the original sample to the second sample, and just compared like the, you know, frequency of new mutations, the change in the variant allele frequency of pre-existing mutations in people who were and were not exposed to cancer therapy. And so we found that most mutations you could detect at both time points. And really what was going on here is that people who had been exposed to cancer therapy had overall like an increase in the VAF, so an increase in like the mutational burden in their blood with therapy. So these were mutations that were present before and that were expanding with treatment. And again, the types of genes that were expanding, like for the most part, were mutations in the DDR pathway, like PPM1D, TP53, and CHEK2. So what we think this like data suggests is that, you know, probably as people age, they develop clonal hematopoiesis, but with different exposures, certain genes have like an increased fitness advantage. And so that leads to them like expanding relative to like people who weren't exposed to that specific CH promoter, which results in these findings where you see like enrichment of certain types of mutations in people who have been exposed to certain things like smoking or oncologic therapy. So, you know, what does this mean for our solid tumor patients? So, you know, secondary leukemia is super rare. You know, and so even though CH is like a major risk factor for secondary leukemia, it's still like the likelihood of someone getting, you know, a leukemia that you see like in clinic that has, you know, a TP53 mutation, you know, on clinical sequencing is still unlikely. But we wanted to understand that more like objectively. So we did a pooled analysis with a bunch of different previously published data sources, and then also, you know, data from MSK. And we tried to understand like what types of patients are at the highest risk of developing leukemia. And so it's really like people that have certain blood count abnormalities, like they have a high MCV, high RDW, which is like that's the red cell distribution width. So the amount of variability there is in their red cells. People that have mutations in genes like TP53, that have high VAF CH, that have multiple CH mutations, those are the people that are at the highest risk of developing secondary leukemia. And, you know, for the most part, what we see when people do go on to develop secondary leukemia is like these CH mutations expand, often with exposure to cytotoxic therapy. And it's that expanding clone that actually is the secondary leukemia clone. So, you know, that means that potentially we could think about, you know, in solid tumor patients avoiding that are at really high risk, maybe reducing the dose or avoiding, you know, high risk therapies that we know expand clonal hematopoiesis. But the issue is that, you know, we give chemotherapy because it saves lives. It prevents disease recurrence, and we know it leads to better outcomes. Yet, for example, like for a woman with breast cancer, the 10-year risk of secondary leukemia is 0.3%. So it's really highly unlikely that like they're going to get secondary leukemia. So you have to be really careful in thinking about like who you would change clinical management for based on such a small risk. So, for this woman that I saw in clinic, we ended up finding that this was clonal hematopoiesis, this TP53 mutation. It was only present, it was present at 0% VAF in her skin fibroblasts, present in a little bit at a very low allelic fraction in the breast cancer tumor sample, actually, that was done for clinical sequencing, which it represents blood contamination. But, her oncologist asked me, what is like the risk of this woman getting adjuvant therapy? Like, should we avoid it? Should we, continue it? If we give her adjuvant therapy, is she going to get leukemia? Which are all valid questions. So to kind of answer some of these situations, we created this synthetic model of absolute risk, kind of using data from multiple sources together to try to get a sense of like what a specific person's actual like lifetime risk would be of AML or MDS after a diagnosis of breast cancer. Like if we were able to incorporate clonal hematopoiesis into their like risk prediction. And so basically what you see is that, most people are at a super, super low risk. And so, knowing about clonal hematopoiesis really doesn't impact their care at all, and it shouldn't impact their care at all. But there is a small tail of women that are at a higher absolute risk. And these would be people, women that have a TP53 mutation at a high VAF with multiple mutations. And so if you imagine like kind of modulating their risk based on kind of simulating whether they do or do not get cytotoxic therapy, you can actually like see that, maybe avoiding cytotoxic therapy for like the highest absolute like, percentiles of risk might make a clinical difference. But this has not been validated. This is just kind of a thought, really more of a thought experiment that we did. And when you have conversations with patients like this, we know really well like the benefit of adjuvant therapy for breast cancer, and this has been assessed. There's like multiple different algorithms that have used clinical trial data to try to estimate like what is the absolute survival benefit for a specific type of woman, if we were to give adjuvant chemotherapy. And that data is really great, and it's used commonly by clinicians to kind of decide whether someone should get adjuvant therapy in breast cancer. And you can use those types of data to have these conversations with women. And so, what I usually do is, work with their oncologist to try to estimate the absolute risk of adjuvant therapy. And then try to put that into the perspective of their clonal hematopoiesis risk. So, if someone's going to get, a 5% benefit in terms of their overall survival, in terms of getting chemotherapy, that's a big benefit. And it would be a really unusual situation where there would be a clonal hematopoiesis, clone that would put that woman at a 5% risk of therapy-related disease. But based on some of these predictive models that our group and others have developed, there might be certain situations where people have really high-risk mutations, abnormal blood counts. Those types of people, maybe the absolute risk kind of getting secondary leukemia is similar to the benefit they might get from chemotherapy. So, I think the things that I want to leave you with today is really just that CH is very common with aging, that you're going to see CH commonly in clinical practice because the genes overlap cancer predisposition genes. And And these include probably most prominently, I'd say most commonly ATM check 2, but also TB53 and even NF1. And look out for, these like reports about a possible mosaic event in the blood. And the way essentially that you would deal with that is through multiple testing of multiple tissues. There's, a lot of people at different academic medical centers who have a lot of expertise in that, and in counseling people that have CH. So, please feel free to reach out to me, and I can, or, that I can hook you up with people, closer to you or even at your own institution, that could talk to patients about this, because like I'm hopefully, explaining the management is a little unclear. And the conversations that we have with patients about their leukemia risk are pretty nuanced, especially since the risk of leukemia is so low. So with that, I want to thank the people in my lab, and thank you guys for inviting me to talk today. Excited to answer any questions.
Great. Thank you for that. This was a really exciting talk, and I know it's really relevant to a lot of us who do solid tumor NGS testing and come across potential CH variants rather frequently. We do have a couple questions in the chat, so I'll actually hop over to those. So regarding multiple tissues, what do you think about saliva and buccal swabs? Would these samples be any different from blood, or any data on comparing these specimens versus blood in terms of CH?
Yeah. So we did a little bit of work on this. There's a paper that's like under review right now, where we compared the frequency, like the variant allele frequency of CH in the blood compared to buccal and or no, it was compared to blood, saliva, and urine and cell-free DNA. And so essentially, like, if you see CH in the blood, you're likely actually to see it especially in like saliva or buccal samples, because there's just so much contamination from leukocytes with those samples. But the variant allele frequency is going to be lower in general. Same with the cell-free DNA. So, in terms of like just using that to distinguish CH from mosaicism, I don't think it would be a reliable way. The tumor is better, especially, like for the most part, there's, efforts to try to like remove blood contamination from the tumor before, the DNA is extracted. But yeah, you're definitely gonna see like CH very easily in saliva and buccal samples. Maybe better is nails. Nails is definitely a better source, for like mosaicism testing. But of course, like the DNA from nails, I think is just like poor quality and lower yields, but that would probably be a better alternative.
Great, thank you. And I was just kind of wondering, like, if you have a patient that had like a previous myeloid neoplasm, what are the risks in trying to report something like CH, and what kind of consideration should be given in that instance?
Yeah, so if someone has a history of myeloid neoplasm, but it's, cured, like they had a bone marrow transplant, then, it's possible that you could be detecting like kind of minimal residual disease.
Mm-hmm.
But a big, like an advantage that you could leverage is that you presumably would have like sequencing of their AML or their MDS, before, so you could look to see if those like mutations were present before.
Mm-hmm.
but it's pretty, unless you are like pretty confident someone is in like a deep remission, for sure it's possible that like what you think you're seeing as clonal hematopoiesis could just be minimal residual disease.
Got it.
But again, you could leverage, like, this more comes up for like research projects, but you could leverage the fact that you have the sequencing data before,
Mhm.
you know, to see if it's the same clones.
Right. Yeah, that would be important. Cool. Thank you.
Yeah.
We have a couple more. Yeah, it looks like we have a couple more questions in the chat. So do you have experience distinguishing CH mutations from other somatic driver mutations in solid tumors or using circulating tumor DNA? So any suggestions or tricks?
Yeah. So, I mean, so, okay. So ideally with like solid tumor sequencing, you know, so say you had a solid tumor sequencing data set, and, you know, ideally you would, like, if you wanted to distinguish, you know, mutations, you would have a matched blood sample. And that way you could readily detect, you know, you can actually use both like the tumor and the blood essentially as like controls for each other. So you would, if you were like going to look for clonal hematopoiesis, you could use the blood. You could run, you know, somatic variant collars in the blood and then use your tumor as like a matched normal. So things that are present in the tumor at similar VAF, you would assume are germline. Things that are enriched in the blood, but are present at much lower levels in the tumor, you presume represent clonal hematopoiesis. And then conversely, things that are present in the tumor but not the blood are, you know, somatic drivers unique to the tumor. If in the absence of a matched blood sample, that's tricky. I mean, there are certain, you can leverage somatic sequencing databases to like identify mutations that are really unlikely to be drivers for that tumor. Like, for example, DNMT3A, that doesn't drive like breast cancer. I don't think there's probably no evidence that it has any relevance there. So presumably if you see like a DNMT3A leukemia hotspot mutation like the R882H variant, you know, at low levels, presumably that's like from blood contamination, that's clonal hematopoiesis. But for other mutations, you know, like TP53, ATM, you know, that's kind of almost impossible, I would say. And, you know, similarly with cell-free DNA, you know, the best case would be that, you know, you would sequence the cell-free DNA and then you would sequence the Buffy as a matched control. And, you know, things that are in the Buffy are clonal hematopoiesis or germline mutations. Things that are present only in the cell-free DNA are coming from a different source than the blood, at least. And again, you can leverage like the fact that there are certain mutations that are just way more likely to be clonal hematopoiesis, like DNMT3A. But good luck with TP53. I think that's impossible.
It's kind
Thank
of
you.
Yeah.
so kind of to follow up on that, I'm wondering what your professional opinion is on mentioning CH in like clinical lab NGS reports that come out and for things like TP53 or DNMT3A.
Yeah, you know, I think I've gone through different like phases of like thinking about this. Like I would say right now, I'm, you know, more in the case, I think disclosing clonal hematopoiesis in the setting of a research study is completely appropriate, right? Like if you tell somebody that, you know, you're going to be doing some research sequencing, you know, would they want to know about like variants of uncertain significance? Would they want to know about clonal hematopoiesis, which really essentially is a variant? I would say you would classify that as more of like a variant of uncertain significance.
Hmm.
Because, some people actually feel very strongly about not wanting to know about those things. So I think you really need to give people a chance to make a decision about that. And so that's one thing. When you're faced though, like with a clinical report, say you're doing like germline testing and you find something that could be mosaic, like you kind of have to tell the patient, right? Like you're going to tell the patient because there's going to be things that you as a clinician need to do to like follow that up, to figure out like how you can best treat them. So you're kind of unavoidable there.
Hmm.
Um, the other way that like this comes up is, when people have, and where this is probably the most relevant, like when people have abnormal blood counts and you're working up their abnormal blood counts, part of that workup commonly involves doing a myeloid panel. And so because of that, you find people that have, it's called CCUS, clonal cytopenia of undetermined significance. That is a very high risk state. People that have CCUS that have, clinically significant abnormal blood counts plus clonal hematopoiesis, they are at a very high risk of progressing to heme malignancy. That is a disease state that I feel also is warranted to, of course, tell patients about. It's a WHO listed, ICC listed, like hematologic condition. So,
Hmm.
but run-of-the-mill clonal hematopoiesis detected on a solid tumor panel, I would say no. I don't think I would treat it just like a VUS, because I think it can lead to patient anxiety, especially because there's nothing to do about it.
Hmm.
There's no intervention as of yet. That might change, but right now there's really no interventions.
Right. Oh, that makes a lot of sense. Thank you. That's a lot to think about. I know a lot of us kind of grapple with that every once in a while. Um, okay, so there's one more question in the chat. It says, I'm wondering if knowing a patient has CH-derived tumors can then inform improvements to follow on treatments.
So maybe like I I think um that might be getting at this idea that like could we use clonal hematopoiesis as like a early prevention tool? And yeah, I think so. We actually have a clinical trial in this space. So again, like we're looking at people that have CCUS, so they have cytopenias, like clinically significant cytopenias and CH. And there's IDH1 and IDH2 inhibitors have been used for many, many years in AML and MDS. They're safe, they're very effective, very few like off-target effects. And we're using that actually as a preventative therapy in CCUS. We have 2 clinical trials, one for IDH1 inhibitors, one for IDH2 inhibitors. And with the idea that like, especially using molecularly targeted therapy, that might actually work best in like an early disease setting, because the mutational burden that you get in CCUS, like, or CH, of course, is like much lower than AML. Like most people with CCUS have 1 or 2 mutations, whereas people with AML or MDS have 4, 5, 6 plus mutations. So, using a genetically targeted therapy like that presumably hopefully will work better. So we're trying things like that to try to like move up the intervention earlier, like when those targeted therapies might have a better chance of actually working long term. And so far the clinical trials are going well and we have good response rates, so they're ongoing. But more on that later, I guess.
Yeah, that makes sense. Paolo, I see you have your hand raised. Go ahead.
Hi. Hi, Kelly. Thanks. That was great talk. A
Thank you.
very important issue for all of us. The tool you mentioned, you use to inform your decision on that case of a patient with breast cancer with clonal hematopoiesis, is that available?
Predict.
Yeah.
Oh, you mean like the clonal hematopoiesis?
You mentioned, yeah, you had a tool for trying to estimate the risk of a patient to develop a myeloid malignancy based on all the history and the clonal hematopoiesis. Is that a tool that is mature, it's available? Because that would be very useful.
Yeah, actually, honestly, better than even that tool. There was like a more recent paper that came out like a few months ago by Lachelle Weeks. They published it in New England Journal of Medicine, and they had like multiple different like validation cohorts. And it was a tool to like estimate like risk of clonal hematopoiesis. The idea is to try to define like a very small proportion of people that are at like very high risk of getting heme malignancy. So I would actually use that instead, because I think it's better like vetted and more applicable in like multiple situations than my tool, which was really developed like specifically for breast cancer and probably too limited for like multiple applications. So that paper,
right.
Paulo, it's if you just look up Weeks, New England Journal of Medicine.
Yeah, I
There you
posted
go.
it in the chat.
Perfect.
Awesome.
Found it. Thank you. Thank you very
Oh,
much.
thank you. So would there be any situation where you might like advise against like radiation therapy or something like that on a patient that is really susceptible to therapy related myeloid neoplasms or to developing those? That is another question.
Yeah, I would say so. There's certain situations like, you could imagine, I don't have like great evidence supporting this, but imagine you're talking to someone with prostate cancer or with breast cancer where they're like deciding between surgical, like more intense surgery versus like maybe lumpectomy plus radiation. And like imagine you had somebody that had a genetic predisposition to heme cancer, or maybe even had a high risk clonal hematopoiesis, especially if they have something like CCUS, where it's actually like a reasonable risk, not 0.3%. Then yeah, I mean, I could imagine bringing that into the conversation would be relevant. Avoiding radiation therapy, when there's really like great alternatives and maybe no clear benefit from doing one or the other. Maybe I would say in those scenarios, for those unique kind of situations, for sure, it probably would make sense, especially in someone maybe that has CCUS or a germline genetic predisposition to heme malignancy.
That could kind of tip the scales one way or away from radiation therapy. Yeah. Makes sense.
Yeah.
All right. Are there any other questions? Wait another minute just to make sure nothing comes through the chat. This was so great. Thank you so, so much for joining us today.
No, thanks
I
for
know
having
I
me.
learned a bunch. Yeah. So, all right. Well, seeing it, no questions. I think I can give everybody about 7 or 8 minutes back to their day. But yeah, thank you so much again for joining us and sharing your expertise. And I think we all have a lot to a lot of helpful information to walk away with today. So really appreciate it.
Yeah, thank you. My pleasure.
All right. Have a
Thank
great
you.
day, everyone.
Thank you.